What are we looking at? That's a good question. You tell me what we're looking at. What up, what up, what up? Yeah, that's a good question, right? What are we looking at? So yesterday, somebody asked, hey, do you mind doing some ultrasound cases for a case of the day? I said, for sure. Then I put up an ultrasound case and I got the least amount of responses out of all the cases of the day. And that's totally understandable because ultrasound is not the norm. Ultrasound is not what you're used to looking at. Ultrasound can be this esoteric, just kind of, what is this if you've never seen it before, if you've never encountered it before, if you're not used to the imaging, all right? So I am going to break this down for you guys, all right? First of all, it's an ultrasound. That's number one, right? We've gotten past that part, right? It's an ultrasound. I want to go over terminology with you first, all right? So ultrasound terminology, and we've done this before, but hey, we're gonna reiterate it and we're just gonna keep hammering it home until you guys get it, until you know it, until you never even have to think about it again, all right? So ultrasound, sound waves, all right? Everybody's seen the ultrasound probe one way or another. The sound waves travel from the probe, go through the soft tissues, bounce off of whatever is in there, and then go back up to the transducer, and then the images get interpreted, all right? That's what ultrasound does. So there are two main footprints of ultrasound, all right? What do I mean by footprints, all right? So two main, right? There are other ones, but two main footprints. Do you see this right here? You see this big kind of like, it looks like I don't know, like a cup, and it's, I don't know, it's nice and broad-based and wide. So this is one footprint, and that's how you know this is a transabdominal probe, all right? If we were dealing with an OB patient, and if this were a transvaginal probe, this would not be broad-based like this. It would actually look like this. It would be tight. It would be kind of like really like a real tight U, or almost to the like a V-ish, all right? But this is like this. So now we know two types of footprints. This is a transabdominal ultrasound, all right? So we've already ruled some things out. It's not really OB. Yes, you can look at OB things via a transabdominal probe, but the sensitivity is not as good. You would rather see things transvaginally. Next thing, when I was talking about terminology, for ultrasound, I want you guys to sound smart. This is the whole point of everything that I'm doing. Not only am I teaching you, I want you to sound smart when you're talking to other clinicians, all right? So ultrasound, echoic, we talked about echogenicity, right? We've talked about it many times in the past. These are the sound waves that are traveling into the body. So there's echoes. The echoes bounce off of the internal organs, go back up, and the ultrasound probe records the echoes. So when we dictate stuff, and when you now look at an ultrasound, you want to talk about the echogenicity of things, all right? So you have three main types of echogenicity. And let's start here. Hyperechoic, hypoechoic. Someone say echo, echo. I did, I really did. Not the hard echo though, right? And then anechoic, all right? So hyper and hypo, that's pretty self-explanatory, right? Hyper is super bright. Hypo, not so bright. Anechoic, just like anything that else that starts with anencephaly, anechoic. If anybody doesn't know what anencephaly is, go look it up. We can talk about it sometime. I'll do a case a day on it. Anyway, anechoic means black. There are no echoes. Nothing's bouncing back. Nothing's going back to the probe. Black, black, black. All right? So let's look at this again. I'm not going to even talk about the organ or whatever it is right now. What I'm talking about is, one, we know it's an ultrasound. Number two, we know it's a transabdominal probe because we looked at the wide footprint. Number three, we're going to start looking at what are the different types of echogenicity on this image. And this image is beautiful because it has all three different types of echogenicity. All right? And if you don't know what is normal, at least just compare these echoes to themselves. How about that, right? Compare this to this to this. Those are your three structures, all right? Which one's hyper, which one's hypo, and which one's an? This is hyper, this is hypo, and this is anechoic. This is black. Black, 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 bright, 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 not so bright, not so black, all right? Those are your three different types. Anechoic, usually when things are anechoic, meaning there are no echoes that are gonna return back to the probe, that means it's probably simple fluid, very, very just simple fluid, water, cyst, nothing really in there. And there's no real like substance for the echo to hit, bounce off of, and then go back up to the probe. Nothing really happens. Say if this is the cyst, the echo from the probe is gonna come down. It's gonna be like, oh, whoa, wait a second. There's like a bunch of simple fluid in here. I don't really have anything to bounce off of. But you know what? This simple fluid is actually gonna make me go faster down through whatever that simple cyst is, all right? And that's why you will hear things called posterior acoustic enhancement, all right? Look at this. Compare this area and then compare this anechoic structure. And then look, can I convince you that there's like this bright stripe going down like this? Do you see that? Can I convince you of that? That's posterior acoustic enhancement. So basically the probe was put up here, the echoes came down, and they're like, whoa, hold on. There's nothing really in here for me to bounce off of and go back up. You know what? I'm just gonna actually speed through this and try to get to the posterior aspect of this and back into some really good tissue, right? And because it's sped through this, there's posterior acoustic enhancement. Remember, this is different than posterior acoustic shadowing. That's not the same thing. That's actually the exact opposite. I'm glad somebody just mentioned stone. Stone is for posterior acoustic shadowing. Because what's gonna happen? Say, for example, this is not the case, but for example, if this were a stone, this is not a stone, just to reiterate. For example, if this were a stone though, the echoes would come down and the echoes could not really penetrate this and go past. They would not be able to. So what is the echo gonna actually do? Instead of going past the object, instead of bouncing around here, it's just gonna kind of hit this periphery and then bounce straight back. So actually the posterior aspect of this is gonna be blacked out. So you're gonna see this black line going down. So that's what you see with calcium or stones, things of that sort. That would be posterior acoustic shadowing. Once again, for anybody just joining, that's not the case. I'm just giving you an example. If this were a stone, you'd see posterior acoustic shadowing. But here, this is anechoic, and we see posterior acoustic enhancement, this stripe that's going down here, all right? Woo, that's a lot of basics of ultrasound right there. So just to reiterate, we have a transabdominal probe. We're looking something in the abdomen. We have gone over hyperechoic, anechoic, and hypoechoic. We've gone over those three things. This one image has all three different variations. We've gone over what posterior acoustic shadowing means. We've gone over posterior acoustic enhancement, what that means. Now we're gonna actually start breaking down the case, right? You got the basics. Oh, you know what? One more basics. How is a patient even positioned when you do an ultrasound, right? So it's kind of hard because this is all flipped. Now I got to flip it back in my mind when I explain this to you. But where is the top of the image? What is the bottom aspect of the image? The bottom, where's the patient's feet? That's the best way to put it. Are the patient's feet that way or are the patient's feet that way? Anybody? The patient's feet are that way. And how do I know that? All right, well, because that's the standard of care when you do ultrasound, all right? When it's a sagittal or a longitudinal. The reason, so when it's labeled, it's gonna be labeled as longitudinal, which is like this. But the reason that I like to say sagittal is because, when you're looking at a CT scan, remember sagittal is cut down this way, right? So I actually just put the probe on and I'm like, hey, imagine I'm reading a CT like this. That's what a longitudinal image is. So when longitudinal images are taken in ultrasound, the feet are gonna be that way and the head's gonna be that way. All right, you guys good with that? Ultrasound images can be taken with an axial cut or AKA a transverse cut. Those are the same things, all right? Axial meaning when you take CT slices, they're like this. That's what an axial or a transverse cut will be in ultrasound. Longitudinal will be like this. But hey, guess what? That's what a sagittal image is, right? And just to clear things up, coronal will be like this on CT, all right? So now you guys all got the terminology down, all right? So now let's break down this actual case. So what organ are we looking at right now? Anybody? A lot of you guys got it. Some people weren't sure. but this is the kidney, all right? This is the kidney, and if you're a superstar, you can tell me which kidney this is, right or left. All right, it's kind of tough on this exam, but I want you to get familiar. This is what the liver looks like, all right? It's a kind of a cruddy image, but this is the liver. You can see there's some portal-like tracks, but this is gonna be the liver, and then this is gonna be the kidney right next to it. So because of that, we know it's the right kidney, all right? The next thing that you need to know, and you won't know this until you've actually seen a bunch, is this normally what the kidney should look like? All right, forget about this. Everybody keeps looking at this stupid thing right here. Forget about this. Remember what I just told you. What is an anechoic structure? An anechoic structure will have simple fluid in it. Therefore, this is a simple cyst. I don't care about that. That's the little red herring that everybody kept looking at going, oh, there's something going on here. I did, however, get a lot of answers that this was hydronephrosis. How do I know this is not hydronephrosis? Well, a couple of things. First of all, hydronephrosis should be midline, right? Because the renal pelvis is around here, and then you're going to have the ureter going down like this. So if I saw hydronephrosis, I should see some area in here ballooned up, and I should see calyces ballooned up as well, right? So I don't really see any of that. All I see is this round circumscribed structure in the periphery of the kidney, not centrally, not anything that looks like a calyx or renal pelvis, nothing like that. I don't see a ureter that's all dilated up. Forget about all that. So this is not hydronephrosis. This is just a simple cyst, all right? So then you got to figure out, what is the echogenicity of a normal kidney? What is it supposed to look like? What are the two main kind of layers of the kidney? All right, this is going back to step one. This is going back to, I don't even know, anatomy class 101 in med school, right? So you have the medulla and you have the cortex, all right? So medulla is the inside, cortex is the outside, right? So you got to figure out now, what would that really be called if we were dictating as a radiologist? I'd be like, oh, I'm talking about maybe corticomedullary differentiation. That's a fancy word. Let's see what this question is. Aren't kidney scans for hydronephrosis done from the flank? What do you mean by that? From the flank? This is probably done from the flank. It's posterior. Flank anywhere from literally right down on the back to kind of like oblique a little. Yeah, that's where they're all done. If it's a peds patient, you can probably see the kidneys anteriorly, but for older patients, no. So cortical medullary differentiation. That's a fancy word, right? What does that mean? That means, am I able to draw a line around where the medulla stops and where the cortex starts? Cortico-medullary differentiation. I reverse it. Medullary, cortex, right? Cortex, medullary. This is the outside of the kidney. This is the inside of the kidney. So cortico-medullary differentiation. Am I able to draw a line between those two to figure out, this is the differentiation, right? Can I do that here? Can you confidently tell me that, this is appropriate corticomedullary differentiation? No, I'm going to answer the question for you. You can't tell me that, because the whole kidney has increased echogenicity. The whole kidney demonstrates increased echogenicity. Therefore, you have loss of corticomedullary differentiation. You cannot tell the difference between the medulla and the cortex. You cannot do that right now, all right? This is the #1 reason for any medicine intern, medicine resident, surgery, OBGYN, whatever service you are on. Anytime a patient's creatinine bumps from, 1.2 to 2.3, your attending gets on the phone with you and you're like, Dr. So-and-so, make sure you go order the renal ultrasound. The kidney function went through the roof. Have you ever actually asked yourself what the hell you're supposed to be looking for on those ultrasound exams? You don't know. It's a knee-jerk reaction that you're just like, oh, I got to order the ultrasound. I don't know what I'm looking for, right? You don't know what you're just ordering the study. This is what you're ordering for. You don't need to order the study. I am telling you off of the ultrasound that his creatinine has bumped, but you already know that. You already know he has some sort of renal disease based upon his labs. So decreased corticomedullary differentiation or increased echogenicity of the liver, if it's an acute process, I'm going to call this medical renal disease. That's all. It just means, the kidney has some sort of abnormality to it. I don't know, whatever happened. Maybe he's not hydrated. Maybe, he's on some sort of medication. Maybe he's septic. I don't know. But if I dictated this, I'm going to say diffuse increased echogenicity of the kidney, loss of corticomedullary differentiation findings consistent with medical renal disease. Next case, simple cyst. I don't really care, right? That's how I'm going to dictate this. Did you really need an ultrasound scan to figure that out? No, you already knew that with the labs. But that's what we're dictating to confirm your creatinine bump on your CBC or whatever, CMP, sorry. So that's what we're looking at, all right? Yes, you could tell me, hey, maybe, you know, there's some hydronephrosis. Maybe that's why their creatinine bumped. Sure, I totally get it. I totally get it. But that's what's happening here, all right? So medical renal disease because of loss of corticomedullary differentiation, diffuse increased echogenicity of the kidney. That's what's happening here, all right? Let me show you what a normal kidney should look like. Boom. Now can you tell me, where is the line that differentiates the medulla from the cortex? You can tell me this now, right? You can tell me that this is bright and this is dark. And you can draw a line easily around that. Man, I'm getting good at looking at my phone and like drawing on the screen. All right, so you can tell me that here. So this is a normal kidney, no hydronephrosis, nothing. There's some of the liver right there. All right, we good to go, right? Next case, no, nothing on this scan. Then you have to ask yourself, on this scan, let's go to this scan real quick. What do you think is causing this brightness? Why is this bright? All right, so then you have to figure out an ultrasound. Man, we're getting a whole like ultrasound lecture right now. It's not even case of the day. You guys are getting like a breakdown of ultrasound. On ultrasound, what things are bright? All right, some of the main ones. Don't concern yourself with some of the like the more like fancy ones that we need to know about. The ones that I want you guys to know about are a few. One is stones, calcium, something calcified, right? Stone. See, everybody loves answering stone, and that's absolutely correct, right? And just to reiterate for anybody joining before, stones, remember, posterior acoustic shadowing, not enhancement. Simple cyst, enhancement. All right, so that's number one. Somebody mentioned air. I love talking about air and ultrasound because that is so hard to see if you're not looking at a lot of ultrasounds and if you haven't trained your eye. To look for free intraperitoneal air, I'll show you a case one day, but there will be a line and you won't have posterior acoustic enhancement. You will not have posterior acoustic shadowing, but you'll have something called dirty shadowing. Anybody can Google that right now, or actually when I'm done with this, go Google it then, right? And you'll have dirty shadowing. That's what air looks like on ultrasound. And yeah, you can get the line will look bright, all right? What is the next main thing that will be bright on ultrasound? Blood, no. Fluid, yes, is dark. I want you to say fat. Fat is bright on ultrasound, all right? So remember that. What's a really good example of that? What is a good example that I can help you with? Oh, hey, let's talk about this. Fat, medulla has a lot of fat in there, all right? There's a lot of fat in here. There you go. This is why the medulla is bright, sorry, because of, you know, some fat in there. That's totally normal. But that's what's causing the brightness in there. So remember that, all right? Fat's going to be bright. Stones are going to be bright. There you go. Hey, somebody just mentioned angiomyolipoma. Don't get me started, you guys. If you want me to go on tangents, I will freaking go on tangents like crazy. You don't even know. Angiomyolipoma is a lesion of the kidney, all right? Do not get confused between a myolipoma, which is a lesion of the adrenal gland. Two completely separate entities, all right? Angiomyolipoma, just think of the words that it consists of. Angio, there's vessels in it. Myel, some other muscle type-ish tissues. And then lipoma, it's got some fat in there. So you put all those three things together, it's in the kidney, angiomyolipoma. Do all of these have to come out? Are they malignant? Well, they don't all have to come out. But once they hit a certain size, oh, guess what? Remember FLOTUS, First Lady of the United States? Yeah, Melania Trump. She had an AML. Oh, guess who she went to? She went to an interventional radiologist, I believe. I'm pretty sure she did. And guess what that interventional radiologist did? They did an embolization of the angiomyolipoma. You don't have to resect these things if you don't want. And what is the reason for having to take care of this angiomyolipoma through through embolization of the artery feeding that. Because that thing has a lot of arteries, it's very vascular. You don't want to biopsy that thing. If you put a needle in there, that thing will bleed like crazy, and then you may end up embolizing it regardless. But once they hit a certain number, like 4 centimeters, then you want to embolize it because it has a greater potential to bleed, and the patient can straight up bleed out. All right, remember, not the same as myolipoma. That's part of the adrenal gland. Why liver angioma have increased echoes? Angioma, when you say angioma, what exactly type of... There's a liver adenoma? Is that what you're referring to? Very important information. Thanks for sharing. Good. I appreciate you guys. Yeah, this is a lot of ultrasound that I just went over right now. Broke it down for you guys. Just to reiterate, real quick, remember the foot plate. This is transabdominal. There's a transvaginal. It will look like this. All right. That was number 1. We went over hyperechoic, hypoechoic, and anechoic. Anechoic is black, simple fluid. They'll have posterior acoustic enhancement. Then there's hyperechoic stones that have posterior acoustic shadowing. Then we went over the positioning, which way should be the patient's feet and which way should be the patient's head. Anytime you're looking at an ultrasound image and it says longitudinal, remember that's the same thing as sagittal on a CT. The head will always be to the screen left and the feet will always be screen right. Unless it's a transverse or an axial view of the ultrasound, then it's just like an axial cut of the CT scan, all right? I think that was pretty much it. We went over corticomedullary differentiation. We went through loss of it. What else? I think that's it, right? We good? Medical renal disease, we talked about that. What else? Should we rule out tuberous sclerosis in a patient with angioma? You're going into step 1 questions. For step 1, they're going to love talking about AMLs. They're going to love talking about tuberous sclerosis with the AMLs. That's kind of step 1. Yes, for radiology boards as well, they like kind of talking about that as well. But when I see an AML, I'm not really going down that route at all. I'm just saying, oh, there's an AML and move on. If they have other sequelae, like they got an MRI of the brain or something, and you saw tubers in the brain, that's a different story, and then you can start thinking about it from there. Whether it would be like flare hyperintense lesions. That's kind of a whole different topic we can go through sometime. What else? You guys got any other questions? Otherwise, I'm about to go eat some dinner. Oh, yeah. I was at work today, and then my segment came onto the news. I'll post that, I don't know, whenever it gets uploaded. Echogenicity, brighter is hyper. Yeah. Remember, hyper, brighter, hyper, hypo, not as bright. And then anechoic. All right? You guys good? Is this live going to be available to watch again? Yes, for the next 24 hours on Instagram, and then I will upload it immediately to my YouTube channel right now. I don't think anybody knows about my YouTube channel. I keep answering questions every single time on my DMs that I have a YouTube channel, which is in my bio. Just click on the link. Go look at all my past cases of the day. It's all there. I don't really like, should I say this every day that it's there? Do both kidneys need to have loss of corticomedullary differentiation? That's a good question. Both kidneys. If both kidneys have loss of corticomedullary differentiation, then you're thinking likely of some sort of systemic process, all right? And medical renal disease can also mean chronic kidney disease, right? Chronic kidneys. This is what chronic kidney disease can look like with these super bright kidneys, right? Chronic kidney disease, CKD, can look like this as well. So if you're thinking both kidneys, you're thinking about a systemic process. If you only see one kidney that's bright, but the other one's completely normal, then you need to start thinking about that there's some sort of insult to that unilateral kidney that's causing that kidney to decrease function. All right, that's a huge hint for life, for anything you do in medicine. A lot of the organs in the body, if they're all affected, if there's more than one organ affected, you need to think about a systemic process. Like kidneys, we just talked about this right now. Liver, if that's affected with the spleen maybe, then think about a systemic process. If only the liver's affected, think maybe there's a liver issue. But start thinking like that when you're really starting to look at cases. All right, guys? All right, guys, I appreciate you guys. We'll pick it up, I don't know, tomorrow sometime. You know how it is. Until then, keep it real. Later.